Well, hi guys, my name is Ron Vilela. I'm one of the relatively new pediatric otolaryngologists over here at Texas Children's in Baylor. I just started in November of 2013, but I'm glad to be able to help you guys with this. Today we're going to be talking about complications of acute otitis media. I'm going to leave out chronic otitis media and things like cholesteatoma because we can spend hours on end just talking about that stuff. So with that, let's dive right in. So this very first slide, we're going to talk about normal ear structures here, and obviously these are very important to talk about because really bad ear infection can cause erosion of a lot of bone in the ear, therefore affecting a lot of the structures that are very much intimately associated or very much in the vicinity of the ear. Namely, these areas, for example, the mastoid bone here. There you have the semicircular canals here. Here's the superior, you have the posterior, and then the lateral will be here. Here you have the cochlea here. In this vicinity, somewhere in here, you will also find the facial nerve, and then this big area right here, you have the brain. There you go. Here's a list of various complications associated with acute otitis media, and I've broken them down into sort of intratemporal complications, as well as extracranial complications, as well as intracranial complications. Obviously, these are all based on vicinity, and we're not going to talk about every single one of these, but we're going to hit the highlights on some of the most important ones here. First, let's just talk about simple ear infections. Obviously, I'm going to assume you guys know what an ear infection looks like, the bulging of an eardrum on an ear exam, and what's actually important in this schematic is noting what you will see on a CAT scan of just simple acute otitis media. So in a simple acute otitis media, what you will see is a lot of ear fluid here. There's fluid in the middle ear space. There's probably fluid in the mastoid space, and that's something that you can easily see on a CAT scan of acute otitis media. What's different in terms of imaging for acute otitis media versus, let's say, acute mastoiditis is that in acute mastoiditis, you actually see some inflammation associated with surrounding ear structures. For example, in this vicinity, you'll see the difference between this vicinity and the lack of inflammation on the opposite side. What's also important to note is that sometimes with mastoiditis, you will notice what we call coalescence. Coalescence is actually bony erosion of some, so you can see some of these little bony septae that you can see on both sides in the mastoid portion of the temporal bone. And sometimes a lot of these bony septae are eroded because of the amount of inflammation that you see in a really bad ear infection. And when you get a lot of this erosion of this bone, then it'll look like more of an open cavity, and this is where we note coalescence. So obviously, on physical examination, you'll note, very importantly, that you'll see some proptosis of the ear, and that's very typical of acute mastoiditis. You will see a significant amount of induration post-auricularly. You'll see a lot of erythema. It'll be very warm, all consistent with an infection. And depending on what you feel back here, if this is very indurated but doesn't feel like there's anything there to drain, then we call that acute mastoiditis. If there is something there to drain, such as an abscess or something like that, then we can note that the acute mastoiditis has now progressed to a subperiosteal abscess. And here's what a subperiosteal abscess will look like on imaging. So here you can see again a lot of fluid in the temporal bone, and you can actually see some of the septations in the mastoid bone are eroded, noting again coalescence of the mastoid bone. And then you can actually see erosion of a significant amount of bone here, causing inflammation from the mastoid to start to seep into the scalp area as well as outside of the temporal bone, causing some significant amount of inflammation that you can see as what we saw in that previous slide. Here on this slide, again, you can see a significant amount of erosion of the temporal bone here, as well as a significant amount of fluid collection. And you can notice fluid collection here, otherwise known as an abscess, which most likely will need surgical drainage. Obviously, this is a a very mature abscess because you can note a lot of, in the periphery, some of the enhancing rim. This is the body's reaction to try and fight off the infection by recruiting as much of your immune system to try and fight off that infection. So this is a depiction of another ear structure that could easily be affected by a really bad ear infection. Here you can see the bony labyrinth. So here you have, this is where the oval window is, where your stapes connects to. This is the vestibule here. This is your superior semicircular canal as well as your lateral semicircular canal here. And then this obviously is your internal auditory canal, which leads the nerves into the to the skull base. Here you can see an erosion right here of either infection, or in this case this is probably cholesteatoma, but nonetheless it can cause erosion into the inner ear structures, causing a labyrinthine fistula. These patients will tend to complain of hearing loss and maybe some dizziness as well as some tinnitus. What's also important to note is something that you've probably heard along the way in your board review of Tullio's phenomenon. Tullio's phenomenon is stimulation from acoustic loud noises that can easily provoke transient imbalance. And this is very much associated with the labyrinthine fistula or labyrinthitis. You can perform a fistula test in the office or in the operating room, and this involves applying either positive or negative pressure to the ear canal here, and this can cause lateral gaze of the eyes in a certain direction depending on the type of pressure that you apply. Again, another inner ear structure or middle ear structure that is easily affected by really bad ear infection is the facial nerve. So the facial nerve, obviously in this patient who demonstrates a significant left facial weakness or paralysis, and this can easily be seen with acute mastoiditis. This obviously has to be differentiated from Bell's palsy because you will note in this patient if really bad ear infection is causing this process to have an abnormal ear exam. So the difference between facial paralysis associated with or complicated by an acute otitis media and just simple Bell's palsy is that in Bell's palsy you will have a normal ear exam. The importance of this slide is to depict the petrous apex, and so the petrous apex you can actually note, which is quite extensively pneumatized in this patient in this area and in this area. And over here you can actually see it as well in this area here and in this area here. And sometimes a really bad ear infection can actually extend into the petrous apex, causing a petrous apicitis. This is important because of some of the structures that are very much intimately associated with this area. So, for example, it occurs behind the eye and cause issues with the eye. It can cause issues with, for example, the cranial nerve 6 or the abducens nerve. So in petrous apicitis, we want to remember something that you probably remember from your boards called Grad-Nigo's triad. And in Grad-Nigo's triad, if you remember, it involves a triad of retroorbital pain as well as sixth nerve palsy and otorrhea. Obviously, a lot of patients with petrous apicitis won't manifest all three at the same time, as it can be pretty random, but if you do see that triad, it's pretty typical for petrous apicitis. So now we're going to move into more of the intracranial complications associated with acute otitis media, and one of the first and probably one of the most common intracranial complications is meningitis. As you guys remember from your early medical school careers, Koenig's sign as well as Brudinsky's sign for meningitis. Obviously, you want to evaluate this diagnostically with a CT scan first to see if there's any other further complications besides just meningitis. Make sure there's not something else going on intracranially. Also, you want to do a CT scan prior to performing any kind of spinal tap to prevent a brain herniation. So here's another intracranial complication you can see here, and you can actually see right here you have an epidural abscess. And once you get into some of these intracranial complications that surgically require treatment, then you want to definitely get your neurosurgical colleagues involved. You don't want to be able to try and tackle this if you're just a regular otolaryngologist like me. Even worse than an epidural abscess is a subdural abscess, which you can see here quite extensively in this patient. Again, making sure that you get your neurosurgical colleagues involved and trying not to tackle this all by yourself. And then last but not least, brain abscess. This unfortunate patient has a large one here, and a different patient here with quite a large brain abscess, which would need drainage by our neurosurgical colleagues. This last intracranial complication is that I'll talk about is sigmoid sinus thrombosis. So if you remember from your ear anatomy that the sigmoid sinus is very much in the vicinity, and inflammation, which can then lead to bony erosion, can cause a thrombus to propagate into the sigmoid sinus. If the thrombus is small, as you can see here, then typically all you need to do is to try and relieve the source of the problem by getting rid of the infection, doing a simple cortical mastoidectomy. But as the thrombus can propagate towards the transverse sinuses or to other sinuses, then it's not so easy to fix. A lot of these patients will have those that sort of picket fence type fever pattern that you will see, as well as issues with a lot of edema in the associated structures. Sometimes you can actually remove some of this clot as you're doing your mastoidectomy. Sometimes the patient may require anticoagulation, which actually is something a bit controversial. But hopefully you don't ever get to see this. So for treatment for most of these issues with acute complications of acute mastoiditis, at the very least, they're going to need some sort of inpatient hospitalization with IV antibiotics. Obviously, you want to cover your normal ear flora that cause ear infections, such as strep pneumo or Haemophilus influenza or Moraxella catarrhalis. And if the patient has acute mastoiditis, the first-line treatment for acute mastoiditis is admission, IV antibiotics, and inserting an ear tube. And you'll actually find that on a lot of your board exams. So make sure to take note of that. But if there is other complications, such as an abscess, whether it be a subperiosteal abscess or a brain abscess or an epidural abscess, well, for the most part, you'll need some sort of incision and drainage procedure for these abscesses, and at the very least, a cortical mastoidectomy. Cortical mastoidectomy is also sort of second-line treatment for acute mastoiditis that doesn't respond to IV antibiotics and insertion of an ear tube. Obviously, as I mentioned before, to try and get your neurosurgical colleagues involved whenever you're dealing with intracranial complications. In terms of issues with facial nerve paralysis or with labyrinthitis, systemic steroids may also be of benefit. Some of the other complications which I won't talk about are Bezold's abscess or otitic hydrocephalus, and so you can read up on those at your leisure. If you have any questions, please feel free to contact me. My contact information is right here at the bottom. I think the most important part of this slide is to note this particular reference, which you can easily find on the internet at our American Academy of Otolaryngology website, and it's totally free. This is perfect for any of you who are either interested in going into otolaryngology as medical students, or even if you're not, then you're just going into other subspecialties such as primary care or internal medicine or any specialty, what have you. That's my talk for today, and if you have any questions, please let me know. Thank you very much.